more time for exhalation, sedation can help with ineffective triggering. And finally, switching to neurally adjusted ventilator assist for those of you that like NAVA would be another way to look at triggering by directly triggering off of the diaphragm function and not after the pressure gradient. And finally, sometimes we just have to accept patients are going to have a little bit of trigger asynchrony sometimes if all else fails. This patient isn't on NAVA, but this ventilator is NAVA capable here. So sorry about that transition there. Let's take a look at this patient here. Again, I'm not giving you all the information you need right now, but can you look at that right now and say, is this person passive or active? Active, yeah. We have veteran respiratory therapists here. So we know the patient's active. And again, if I give you more information, it's a lot more obvious because you see that pink bar that says this is a patient-initiated breath. But you all are a lot more savvy than that and recognize that this pressure tracing is not normal. So we don't have a linear or shark fin shape to that, but there's irregularity or scalloped border to that. And that's an example of flow asynchrony. So what is the flow on this patient? Again, I don't know exactly what it is, but I'll show you what it is. So flow is set, and sorry, screens are asynchronous here. So flow on this patient is set about 43. Again, that's a fairly commonly set flow that I see in patients. But what we're seeing here, again, is this patient didn't like that flow. This patient, rather than accepting the flow, is actually trying to pull harder, and you can see the pressure is actually coming down from the pressure that you would accept, and that's evidence that the patient is pulling harder, decreasing pressure, and that results in that tracing that you all are savvy enough to recognize. Again, that's evidence of flow asynchrony. Flow asynchrony develops when demand is higher than that delivered, and it's going to develop in that scalloped pressure curve that I talked about. Really, flow asynchrony can occur at any flow, but it's much more common in any time that the flow is set less than 50. You're going to see a lot of flow asynchrony in these patients. Who cares if you have flow asynchrony? Is that a problem? It makes the pictures look different. Does that really matter? I'll get back to that. But in the meantime, if we do care about flow asynchrony, how can we adjust that? Well, we can increase the flow, give them the flow that the patient wants, or we can also do overdrive, increasing the respiratory rate or the tidal volume to make them care less, to decrease their respiratory drive, and therefore they will pull less hard and not have that flow asynchrony. But here's why I think we should care about that flow asynchrony, and that gets back to that horrible animal study that we talked about earlier that took a lot of time to comprehend. But really, when we talked about esophageal pressures and localized pleural pressures and how they were excessive in spontaneously breathing patients and goes away when we take away respiratory drive with paralysis, we're actually seeing a change in shape of that flow pattern. And maybe some of you saw this early on. I said flow, but I meant pressure, excuse me. Here we have a normal pressure curve with sort of a shark fin, but here what we see is that scalloped and actually inverted concave pattern. Again, evidence of flow asynchrony in these animals, and that flow asynchrony or patient effort results in injurious transpulmonary pressures and injurious distribution of lung volumes. So flow asynchrony is actually very dangerous to our patients, perhaps underappreciated for many years or decades, but something we really need to be thinking about. And again, that's why thinking about flows, even though a normal person's flow for you and I sitting in this conference room might be much, much lower than 50 or 60, in critically ill patients, most of our patients are going to need flows of close to 60. Again, most of our patients are going to want that flow of about 60. But once you set that 60, you have an opportunity to look at your flow wave pattern. Some people are going to need even more flow than 60. Up to 70 is sometimes needed. But hardly anyone's going to tolerate a flow less than 50 without extreme amounts of sedation and or paralysis. If flow is too low, Again, that's flow dysynchrony that develops, and that's going to increase result in the increased work of breathing and the potential of auto-PEEP as well. As inspiratory time is increased with low flows, then you have less time to exhale, and the potential for auto-PEEP is certainly there as well. If you set the flow too high, that can actually result in tachypnea. When I talked about work of breathing a long time ago, there's stretch receptors and flow receptors, and if the flow is set too high, some patients will actually develop tachypnea. Also, increased flow is going to increase your peak pressure, but as we know, increased flow is not going to change your plateau pressure, because by definition, plateau pressure is in the absence of flow. So who cares if your peak pressure goes up just by increasing your flow? So try to ignore that value, even though the alarm will start going off, but change your alarm, not the ventilator. A little bit more about work of breathing and how your mode might affect your work of breathing. This was a study 13 years ago now that looked at 14 patients, and they were randomized to develop or to be put on all three modes: PRVC, pressure control ventilation, and volume control ventilation in random order, but each patient went through all three of them. And they measured work of breathing through pulmonary mechanics and found that work of breathing was actually lowest in volume control ventilation, compared to either pressure control or PRVC. What they also found was that tidal volume, even though every mode was set for a target pressure of 6.4 mils per kilogram. I'm not sure why they chose 6.4, but that's what they were trying to achieve. And in volume control ventilation, they were very close to that 6.4, but both pressure control and PRVC actually resulted in higher tidal volumes than volume control. So less effective at controlling tidal volumes than volume control ventilation. Again, worth recognizing that peak pressure was actually highest in volume control ventilation compared to the other ones. And that often makes people think, oh, I don't want peak pressures that are that high. But again, the peak pressures in volume control are largely related to the flow that these patients are getting. And again, who cares what their peak pressure is as long as their plateau pressure is maintained. One of the reasons that I wonder about why these patients have increased work of breathing in PRVC and pressure control ventilation is the flow pattern, right? Particularly if you use volume control with a square waveform, flow is going to be constant throughout the breath. In both pressure control and PRVC, as the breath goes in, flow is going to decrease over the duration of that breath. And towards the middle and end of that breath, flow is going to be a lot less than 60. And many of those patients are going to develop flow asynchrony that isn't as well visualized on pressure control and PRVC. And so they're going to have increased work of breathing because of their inadequate flows or unachieved flows. Look at another patient here. This patient's ARDS does not have any asynchrony because the patient's paralyzed. That makes that part easy. What abnormalities do we see in this patient? So again, one of the things I see is that a peak pressure of 37 here. What else do we see? Why is that peak pressure so high? Again, we've sort of talked about some of these things. Just looking at the waveforms, so a second is from here to here. This person's inspiratory time is about 3/4 of a second. And unless we're giving 800 cc tidal volumes, that person's flow is probably pretty low. And again, if we look at the flow tracing, we can see flow is significantly less than 60. And again, this person doesn't have asynchrony because they're paralyzed, so who cares about that flow? But again, this is the patient that, because inspiratory time is so long, we've now run out of expiratory time for this patient. And this is the patient that has persistent expiratory flow at end expiration, suggestive of auto-PEEP. And again, even though the asynchrony is not a problem, the low flow rates result in high inspiratory times and therefore decreased time for exhalation. Sorry, go through those things. All right, next patient. Again, sorry, lower quality graphics here. This is a patient with influenza, MRSA, pneumonia. And what do you see in this person's waveforms, besides my reflection in my phone? So pressure's 39, so higher than we like to see, you bet. Trigger asynchrony, you bet. So by trigger asynchrony, you're seeing this right here that says, I'm trying to take a breath here. And so this is a subtle difference, and it may just be semantics. Because of the location of this patient effort, right at the end of inspiration, we're actually going to call that a different type of asynchrony, but it certainly is asynchrony. And this is actually an example of cycle asynchrony. Again, semantics. Cycle asynchrony is defined as a discrepancy a discrepancy regarding when the ventilator says it's time to change from inspiration to expiration, between that and when the patient says it's time to change from inspiratory to expiratory time. And really what we're talking about is most patients have a neural time constant that says, I want my breath to last this long. And the ventilator says, well, I'm cutting off here. And the patient says, no, I still want that breath. And they're going to try to keep taking that breath even after the ventilator cuts the breath off. So really have persistent inspiratory effort after the ventilator stops. So why is cycle asynchrony a problem? Well, the ultimate in cycle asynchrony is going to be these double-stacked breaths that many people see. The problem with these double-stacked breaths is it's actually not a double-stacked breath, but it's really a big breath with two different efforts in there. And what we know is that if we set the tidal volume at about 6 cc's per kilogram, when we have double-stacked breaths, the actual breath that goes into the patient is going to be about 9 to 10 cc's per kilogram. And so, again, clearly injurious lung volumes in these patients with these stacked breaths. In one study, we found that 45% of patients are going to have greater than 6 stacked breaths per minute over a 12-hour time period. Again, that's a lot of stacked breaths, a lot of injurious ventilation going on, despite attempts to provide lung protective ventilation with 6 cc's per kilogram. A major risk factor for cycle asynchrony is, in fact, low tidal volume ventilation. Again, you're not giving a patient a very, very big breath. They're not going to be happy with the duration of that breath. And also data shows that asynchrony is more common in volume control ventilation. So I've been touting volume control ventilation up to this point. Asynchrony is more common in volume control ventilation. And again, asynchrony can result in increased work of breathing if it's left unchecked. I do think it's important to differentiate asynchrony, which is an unconscious, primal part of the brain that says, breathe now. Separate that from discomfort, which is a conscious part of the brain saying, I don't like this. Those are different things. But if we think about, our brain is set to make us breathe even when we're unconscious for the most part. Again, that's a very low in the brain function that says, time to take a breath. And that really is different than a patient that is uncomfortable, is trying to breathe because they're uncomfortable. And when we think about that, how do we respond to cycle asynchrony? Well, one thing would be to change the tidal volume. Like we talked about, low tidal volume ventilation is associated with asynchrony. So in this study, they went from 6 cc's per kilogram to 7.5 cc's per kilogram to 9 cc's per kilogram and found that cycle asynchrony decreased when they increased tidal volume. Again, that seems fairly straightforward, increasing the tidal volume. In addition to increasing the tidal volume, one could change the mode to a mode that's associated with less asynchrony. That certainly is an option. And you can increase the inspiratory time, like we talked about. If a person has their neural time constant is larger than the set inspiratory time, we'll increase the inspiratory time, and the patient may be happier with that. Again, there may be drawbacks to many of these things. In addition to adjusting the ventilator, many people are going to try to adjust the patient by giving increased sedation. And if that doesn't work, paralyzing the patient. And that certainly gets rid of all asynchrony, is paralyzing the patient. But as we talked about, paralysis also has downsides as well. outside of a very limited time period and set of patients. So let's talk about adjusting the ventilator for these patients with cycle asynchrony. Again, think about asynchrony as an unconscious or subconscious phenomenon, not a conscious phenomenon. And that is relevant when we think about when we try to sedate these patients. This is a study that looked at patients that had asynchrony, and they measured something we call breath stacking index, which is really just how many breath stacks they had per minute, divided by respiratory rate. And what they found is when they gave boluses of sedation or analgesia, the breath stacking index decreased a little bit, not very much. Again, you know, the drive to breathe is not a conscious thing, so making someone unconscious doesn't take away the drive to breathe very effectively. You have to